Okay, good morning, everyone. I'm delighted to introduce our Grand Round speaker today. Today is a very special day because on this day, September 7th, 32 years ago, Juan Perotti implanted the very first aortic stent graft on the planet. And it couldn't be more fitting for us to have Andy Schanzer with us today, giving us a talk on his aortic dream. Andy serves as the professor in chief of the Division of Vascular Surgery at the University of Massachusetts. He went to Harvard, then he went to NYU for his medical school. He then came out to the West Coast to UC Davis to do his general surgery residency, and then did his fellowship at the Brigham and Women's in Boston. He is the past program director for the fellowship and residency training program, which he started in 2010. He is the director of the University of Massachusetts Memorial Center for Complex Aortic Disease. That is from 2014 to present, so for the past 8 years. He is the medical director of the University of Massachusetts Heart and Vascular Center of Excellence, which was started in 2019. He received in 2020 one of the highest awards at the University of Massachusetts, Outstanding Clinical Educator and Mentor Award from the medical students. He is a reviewer for over 22 peer-reviewed journals. He has been the principal investigator or associate principal investigator for 24 industry-sponsored clinical trials. He is the immediate past president of the New England Society for Vascular Surgery. He has had many roles in the American Board of Surgery to include counselor and director of the Vascular Surgery Board. He is the author or co-author of 196 peer-reviewed publications with 39 as first author, 40 book chapters, 191 presentations at regional or national meetings. He's a husband and father. His kids are Ben, Danny, who is here with us today, and Emily, and most importantly, he's a great person. I should say that today is his son Danny's birthday. He's 15 years old today. I feel like we should sing happy birthday to you. But Andy accepted our invitation to come out here and give grand rounds on this day. And Danny said, well, Dad, you know that's my birthday. And so they agreed that Danny would come with him. And I think Danny is in love with the great Pacific Northwest. So the title of Dr. Schanzer's talk today is Personal Reflections, Chasing an Aortic Dream, Getting from Here to There. So Dr. Schanzer, thank you.
Well, thank you very much. That was a very generous introduction, and even some of it was true. So thank you. So this is a little bit different than kind of the talks I usually give. I'm not going to sort of go through all the data around complex aortic repair, which is kind of generally what I speak towards. Ben had asked me to talk a little bit more kind of personally about how we developed our program and how we kind of got from here to there. So hopefully that will be interesting to you. I do want to start by saying, first of all, thank you for the opportunity to be here. It really is an honor. And we talked a little bit last night at dinner about really what a great group this is. So very fun for me to be able to visit with you. These are my disclosures. Work with these companies. I will mention some of their devices, some of their technologies. None of the compensation comes to me. So I'll frame this talk in the context of the aorta, really the area that I think is the most exciting in vascular surgery, and what I would argue is really undergoing the most innovation in the way in which it develops right now of really any surgical field. But in some ways, I'm kind of preaching to the converted here because I know that this group has done really an amazing job pushing aortic technologies. And I would put the UW Vascular Group really in the top 5 nationally of really aortic centers of excellence. So let me start here. So this is a long time ago. This is when I started my residency at UC Davis, and this is kind of where it started. And I sort of put this up for 2 reasons. One is because I did have black hair at one time, and I like to show that. And then the second is I kind of had this distorted view of career development at that time. And this is kind of for the junior folks, but I thought this is what career development looked like. I thought it was sort of this linear path where you sort of go to college, then you go to med school, or then you go to residency, then you train, and then and really what I've learned over time is that it's not a linear path. It's kind of what you make of it, and you see a bunch of dots, and sometimes you make some more forward progress, and sometimes you make a little less forward progress and maybe drop down. But hopefully, as you take these series of dots and kind of lay them out together, you end up with something like this, ideally, some sort of progression from point A to point B. So what I'm hoping to do today is tell you a little bit about my dots and some of the things that I've found to be sort of key inflection points in the way we developed our aortic practice. So let me just kind of provide some background for the larger group. So abdominal aortic aneurysms account for 16,000 deaths annually. It's a 13th leading cause of death in the US, and it's the 10th leading cause of death in men over age 55. I think everyone in this group knows the natural history is expansion followed by rupture with growth of about 0.2 to 0.4 centimeters per year expected. And really, when I see a patient in the office, this is what I'm doing. I'm sort of balancing what's the risk of observing them with their risk of rupture and risk of death from rupture versus their risk of repair with the associated morbidity, mortality, and secondary procedures. And that's kind of the algorithm that we run through. And we have pretty good data to inform the threshold at which we offer repair. So I think most would agree based on large randomized trials that for men, the threshold is about 5.5 centimeters. For women, probably about 5 centimeters given smaller size and less women represented in these studies. And since around the 1950s, we've been doing open repair and we've been doing it well. This is direct exposure, either transabdominal or retroperitoneal. We get proximal and distal control and we sew in a prosthetic graft. And we can sew that in to fit the anatomy. And we've learned that it's effective and durable, it works well. But there's 5 to 10% mortality in population-based studies, and I'll show you some data to support that. I know that seems high, 5 to 10%. Because you're used to thinking about centers of excellence like this one, but I'll show you that. There's 15 to 30% significant morbidity. The recovery, despite the fact that we get them out of the hospital in 4 to 10 days, is about 2 to 3 months, and high-risk patients are often denied repair. And I just kind of show you this. This is from a meta-analysis that looked at a bunch of different reports. It's kind of dated, but I think the data still carry forward that you can have single-center reports with this mortality of 2%, a place like the University of Washington. But when you look at multi-center reports or population-based reports, it really is more like 5%. And I'll ask you to kind of remember that number because that'll come up a little bit later. So Ben alluded to this. So there was really a transformative moment on this day in 1991. And that's when these two pioneers really showed that endovascular aneurysm repair was possible. And I'll point out that Juan Perotti was actually the first visiting lecturer for this lectureship, which is an honor to really follow that lineage. And then soon thereafter, it came to the United States. And you'll notice the last author here is Frank Vieth, another one that has been here for this lectureship. So again, really an honor for me to be part of that. Now, it's important for everyone to understand that endovascular repair is totally different than open repair. So instead of cutting out the aneurysm sewn in a graft, we're excluding the aneurysm from the circulation. So the device is inserted from the groins, it's positioned with X-ray guidance, and the aneurysm is excluded with a covered stent system. And we've seen that pendulum swing fast. So now, in the last 30 years, in the United States, over 80% of infrarenal elective repairs are performed utilizing EVAR. And I just want to point out, again, this fundamental difference. So with open repair, we can effectively deal with any AAA morphology. We cut the graft to fit the patient's anatomy. Whereas with endovascular, favorable anatomy is essential because as you see here, with open, we fit the graft to be able to sew to a normal artery above, normal arteries below. But with endovascular, we really need some anatomic criteria. And I won't go through the numbers, but suffice it to say you need a good area at the top to seal a graft, and you need a good area at the bottom to seal a graft. And as we get increased deviations from ideal, we get increased chances from failure. And we've had the opportunity to kind of summarize some of the differences between open and endo. And I just want to summarize it for you kind of with one slide. This is a slide looking at two of the largest randomized controlled trials. And what we see with endo compared to open is that there's decreased mean operative time, decreased estimated blood loss, decreased blood products, decreased length of ICU stay, decreased overall length of stay, and then most importantly, this 5-fold decrease in perioperative mortality. And that's where, again, I point out that elective, in the context of a trial, open repair has a mortality somewhere on the order of 4 to 5%. So it was our view that if you could take an operation like this, that we can do really well and reduce the mortality 5%, from 5 to around 1%, then perhaps it's actually these aneurysms, the more complex aneurysms, where you can really get benefit from coming up with a minimally invasive strategy. Because the open alternative here is a big operation, and it looks really pretty in illustrations like this. But in real life, it's a pretty big exposure. You guys do it well here. There aren't many centers in the world right now that do a high volume and do it well. It's an important skill set for us to have. But I think if you look at sort of the landmark studies, and these are the 3 largest studies ever to look at thoraco at high volume centers where they do it really well, you can see that the 30-day mortality is not negligible, even at these big centers that do it well. And what's kind of more sobering is if you look out into the general population. So this is a study that Dave Rigberg did with the UCLA group, looking at open thoraco repair results in the California statewide database, and showed that overall elective mortality was 19% at 30 days and 31% at 12 months. So I think with that context, at least as a group, we found ourselves at a bit of a crossroads. Do we continue doing sort of more open surgery for complex aortic repair, understanding that there are challenges? Or do we look to see if we can sort of develop new technologies? And that's really what led to our desire and development of a fenestrated branched endovascular program. And I just want to, for the general audience, I just want to go over these photographs really quickly because it kind of frames the rest of the talk. So all the way on the far side of the screen, you can see a scallop. That's just a cutout in fabric that lets you bring a graft a little bit higher. So you can imagine a renal artery, and now you can bring fabric right up to the base of it. The next image in the center is a fenestration, fenestra being a window in Greek, which is just a hole in the graft. So now you can actually bring the graft up and incorporate a target artery through that fabric, through that hole, and have fabric above it. And then directional branches, similar type of concept, but a little bit of a cuff for different type of apposition. So how did we go about thinking about our program? Really, it started back in 2008. So I finished my fellowship in 2007 and really wanted to think about how we could develop a complex endovascular program. And we wrote this paper at the request of JVS when we were developing our program about how we did it. And I just want to point out some kind of salient features from it. We used regular routine survey methodology for all the different stakeholders and came up with sort of the key programmatic elements. So I think first of all, it's critically important to get on-site training and establish international centers of excellence in complex endovascular intervention. And I think what I like to point out to people who ask me about this is this isn't just going to the OR and seeing a case. It's really understanding the process of how you do case review, how you plan these cases, how you select the right device, and what type of procedural conduct is necessary. What do you need from a team in order to make these successful? So I had the opportunity to go to a few places. I went to the Cleveland Clinic, I went to the University of Washington, spent some time with Ben, and I went to Lille, France. And let me just kind of walk you through some of the lessons I learned there. So this is actually Roy Greenberg, one of the pioneers that developed this technology. And I point out this email and talked to a few people about this at dinner, but I just wanted to point out the date. So that's July 1st of 2007. That's the day after I finished my fellowship in vascular surgery. And I reached out to Roy and I said, I saw you give a talk, an invited talk on fenestrated branched, and I'd really like to learn more about that. And the reason I bring this up for kind of the junior folks and the residents is because I had nothing to bring to the table here. I reached out to Roy, not with an introduction, not with any research chops in fenestrated branched endografting. In fact, I had never seen a fenestrated or branched endovascular repair. And what's interesting is that just by putting forth a little bit of, I'd say, enthusiasm and passion, that led to really a lifelong relationship. And unfortunately, Roy ended up passing away, but someone that was really a key inflection point in my development. And I like to point this out as well, that the first 10 fenestrated cases I did, I sent Roy a copy of my plan. And he looked at him, and several of them, he said, "You're nuts, don't do that." And several of them, he said, "That sounds like a great plan." And the reason I bring that up is because I think it's important when you're working on these new technologies and sort of on the front edge of something to kind of try to set yourself up for success as much as possible. And you'll see that's kind of a recurring theme. As I got into doing arch work, Roy recommended that I spend some time with Stefan Howlon in Lille, France. He's become really a great friend and a great colleague. And again, along the lines of sort of setting you up for success, I flew him out for my first 2 branched arch grafts because I wanted someone in the operating room with the most experience in the world to help me deliver the best care I could to the patients in front of me. A little side note there, I highly recommend if you're going to form collaborations with people, find people that have a chalet in the Alps. It's a really nice side benefit. We go backcountry skiing every year for the last 6 years, and it's an amazing area if you haven't been to the Alps yet. I then hooked up with this guy. So when I started learning about these technologies, it became very clear that I didn't have access to these company manufactured devices that I was seeing Roy Greenberg put in at the Cleveland Clinic, that I was seeing Stefan Howlon put in Lille, France. And I learned about the really innovative work that Ben Starnes was doing with physician modified endografts, and reached out to him, and he was kind enough to have me come over, and I was able to learn some of the techniques that you guys have seen that really have been developed here by Dr. Starnes. And this is just an example of a case that really what I learned here at the University of Washington, opening grafts in the same conference room we were in yesterday where you presented cases to me, allowed me to treat this patient. So this is a 72-year-old transferred from an outside hospital with epigastric pain radiating to the back. He had a previous open AAA repair and an ejection fraction of 25%. You can see on his CT scan, he's got a relatively normal descending thoracic aorta. Then you start to see some blood in the retroperitoneum as you get to the, below the chest. You can see the start of the aneurysm at the level of the celiac, a clear rupture at the level of the SMA, and then going down, you see, which is pretty uncommon actually, but a blush outside of that into the retroperitoneum, and then the aneurysm. So in summary, EF at 25%, acute rupture at the level of the visceral segment. This is a hard problem to get a patient through with an open repair. So much like Dr. Starnes taught me, we make a very sophisticated computer-generated drawing here. Obviously kind of a back of the napkin type of calculation, but we do this off of a 3-dimensional workstation. We mark out exactly where all the vessels are, what the arc lengths are to cut these fenestrations to get them in the right spot. And then I love this phrase. I don't know if you remember saying this, Ben, but I kind of steal it from you all the time. So you then practice endo black magic sorcery, where you open the device, you put your marks where you need your fenestrations. Sometimes we always reinforce them. We use these gold rings. Sometimes we'll put on these mini cuffs to increase the apposition if there's a significant bridging distance from where the graft's going to be and where the target artery is going to be. And then we kind of scrunch it all up and put it back in the sheath. This was an old case, and before we were using fusion regularly. So now you can see the far pane, we've got marking catheters outside of the graft into the target arteries. Then we cannulate inside the fenestrated endograft, out the fenestration into the target artery. Then balloon mold that graft to the previous open infrarenal repair, ideally get a seal at the top and bottom. And I chose this case because I just saw him last Monday, and he was in the ICU for 24 hours. He just discharged on post-op day 3, and he's now got 9-year follow-up, doing well, stable creatinine. And this question that I think Ben got asked a lot, like, can you really burn these holes and make a durable graft? I think the answer from the work that your group has done here, as well as now others, it is durable, and it's a really great solution. And I think without having sort of learned that from Dr. Starnes, I'm not sure I would have gotten this patient through this repair with an open repair in that setting. The other thing I'll point out is kind of remember where you came from and sort of who taught you what. So, you know, I sent this to Ben. You can see this was November 19th when we did our 400th case in our IDE. And, you know, just wanted to recognize that flew him out for our first case. He was there, the first fenestrated case I've ever done. And again, setting yourself up for success. It's really nice to have someone in the room who can say, you know what, you're doing a pretty good job and you're taking really good care of your patient. Second programmatic element is you do need industry partnerships to improve access to these developing technologies. And I would say that's a really tricky dance, and it's something we're sort of inherently a little bit uncomfortable with, but I think it's really important. So we vetted different device manufacturers. We tried to come up with a mutually beneficial relationship where we could help them to test and develop these technologies. That led to significant trial involvement in most of the fenestrated branch trials that have happened in the US and got us sort of in the world of having access to these devices. It's also been really important for us to have a fully integrated team approach, but to have one leader that's involved in all steps of the case. There just aren't enough of these cases so I have a group of 10 vascular surgeons for kind of everyone to be doing their own case all the time, like we would do for other more routine vascular surgery. But we wanted to ensure that the skill set required is sort of maximized. I had the opportunity to sort of lead that program and not have it diluted among everyone. But at the same time, in order for something like this to be successful, you have to ensure buy-in from the entire division. So we tried to do that a couple of ways. So if anyone in my group refers a patient to the complex aortic program, they're involved in all aspects of planning, procedure, and follow-up. And one thing we did to kind of take the financial incentive out of it is I have the referring provider in my group bill for the procedure. So we do it together, but we have them bill for it just so it was a non-issue with kind of who's bringing the cases and benefiting from them. Prospective data collection is key to any new program. And really from the start, we wanted to demonstrate acceptable clinical outcomes in order to be successful. IRB approved prospective registry is how we started the program. And then that ultimately evolved to development and implementation of a physician-sponsored IDE. And this is what we put together in October of 2013. Really the primary objective being to evaluate custom-made device and physician-modified approved devices for the treatment of patients with complex abdominal, thoracoabdominal, and arch aneurysms. We use an external clinical research organization. So the New England Research Institute comes in twice a year and audits our books. We use an outside clinical events committee with 3 doctors around the US that look at every one of our major adverse events. And we use a core imaging lab out of the Cleveland Clinic that reviews every single CT scan that's done through the study. And that comes with significant resource needs, but we felt it was really important to run it as rigorously as we could. And we've been fortunate to see the program grow. So now, last Tuesday, we just did our 458th patient in the ID, which is exciting to kind of have seen that grow. And these are the primary devices we use. So we have access to 2 of the off-the-shelf devices that are made by Cook Medical. That's the P branch and T branch device. And then the majority of what we use are these custom devices where the way our ID is written, we can have up to 6 branches and or fenestrations in all different configurations. We use fenestrations and branches. So fenestrations, we use small and large. Generally speaking, we use fenestration when there's a narrow aortic lumen and when there's upgoing arteries. And then we use branches in different types of configurations when there's a large lumen aorta and downgoing arteries. I'll just show you a little bit about our outcomes. So looking at our outcomes, our last data freeze for the FDA was 418 patients. So you can see 48 physician modified grafts, 370 company manufactured grafts, kind of the standard demographics. The only thing I'd point out that I think is really interesting is somewhere around 20 to 25% are actually patients that have had prior EVAR or prior TVAR. And that's very consistent with the national experience. So we're fixing a lot of patients that had already previous attempts at repair. Really the full aneurysm extent from the most standard sort of common iliac aneurysm and branch devices up to thoracoabdominal aneurysms. You can see here the distribution of the different Crawford extents, but many of these extensive, type 2, type 3 thoracos. When we look at the target arteries, we've incorporated 1,704 target arteries. And the majority of these cases you can see are 3 and 4 vessel cases. That's really become the norm for us with an average now of 4 target arteries per patient. Our technical success has been reasonable at 94%. We have had 31 intraoperative branch occlusions for a rate of 1.8%. Some of those are arteries that we knew were very stenotic, that we went in with a plan that we may have to plug the branch or fenestration to it. When we look at our 30-day outcomes, again, taking the comparator of our experience with open thoraco repair, we found it to be very acceptable with a mortality of 3.8%, paralysis rate of 1%. And then you can see a smattering of other complications, but all well below 10%, with a very, very low stroke rate as well. I think what's kind of amazing for these types of cases is the length of stay. So our median length of stay is 3 days and our median ICU stay is 1. And that's only patients that get lumbar drains that get monitored overnight. When we look at our 1-year outcomes for our primary endpoints, 86% survival, 90% freedom from type 1 or 3 endoleak, and 93% target artery patency. And we've used this data to write a number of reports on sort of different aspects of fenestrated branch repair. But as we've written these reports, almost every one of them has had a statement like this. These findings may be limited due to the potential for a type 1 error secondary to limited statistical power. So even being a high volume center now with over 450 of these repairs, we haven't been able to do answer all the questions that we've really wanted to with low frequency event rates. And it's really with that context that I come to sort of another inflection point, and that's the development of the United States Aortic Research Consortium. Your group here has been a key partner in that. Matt and Sarah have both provided really great leadership in developing this. And for those that don't know what this is, we've been able to come together with the 10 US sites that have these IDEs. They all have prospective physician-sponsored studies, independent monitoring by the FDA, and similar device designs with selective use of fenestrations and branches. And it's really my feeling that the past is kind of these single center reports that I was sort of speaking towards. And the future is really these combined larger data, larger, more generalizable data. And, you know, how did this start? It started really organically, again, kind of like a key email. So this was February of 2018. Some of us decided to get together and start thinking about how could we combine our data. And what we learned really quickly is that the way the University of Washington codes an MI and the way UMass codes an MI is totally different. And it was surprising to me because not only was it some of these endpoints, but really kind of basic variables that we thought everyone was collecting the same way were all very different. So we went through a process where we looked at everyone's CRF forms, and then we started having conference calls, and we were doing them once a month, and we were doing this actually for 2 years in order to basically go through each part of the journey of a patient going through a fenestrated branch endovascular repair. And someone would lead the discussion. So for example, like we'd have Matt Sweet take on the variable list for discharge variables, and we'd all run through it, and he'd tell us where there was commonality, where there were differences, and then we'd try to come to consensus. You'll maybe be surprised, but when you get 10 folks in the room that think they're like the best in the world at doing a new therapy, it's actually a lot harder to get consensus than one would think. But I think it was great to sort of see this collaboration. And we basically arrived at a bunch of Excel spreadsheets that looked like this. So 3 columns. What's the variable name? What's the definition? And how are we going to code it? And we need to all do this the same way. So we engaged the FDA in this process to kind of bring them into the loop that we are doing this. They were very supportive of it. And that really got us to kind of the second generation where we are now of the United States Aortic Research Consortium. We created a memorandum of understanding so that we knew what we were being held accountable to. We created bylaws in order to make sure that we could actually hold each other accountable to sort of providing these types of data. We were able to get funding to have an electronic data capture system. So this is screenshots from my computer, actually on the plane ride here, where you can see how you enter it online. We have every module where you can print CRF forms and do it on paper or do it directly into the system. We have data quality queries, so it'll tell you where things are out of range or where things seem to be more than a standard deviation away from the mean. We're able to real-time download databases. So we can download a de-identified entire ARC database as long as we have consent from the group to do that. Or we can always download our own identified data. So I can go in today and download all of UMass data with all the identifiers. And this is September 2nd. So you can see now we're at 2,549 consecutive cases, all done within an IDE, largest data set in the world, with the feeling really being that working together, I think we can accomplish a lot more than doing it apart. And I'll show you some of the work that's now come out of that, and I'll just kind of summarize it. So this was the first paper, 240 patients looking at post-dissection versus degenerative thoraco, with the conclusion that fenestrated branched EVAR was safe and effective with nearly similar outcomes. And patients with post-dissection had more type 2 endoleaks during follow-up and did require more reinterventions. The next study was with 564 patients. This was led by the UT Southwestern group looking at preloaded branches, so using wires to facilitate cannulations. And it showed that the expanded use of preloaded catheters and wires of fenestrations and branches for target artery incorporation is associated with higher technical success and lower early mortality. Next was 661 patients. This was led by the Cornell group, target artery outcomes after branched and fenestrated repair, showing that selective use of fenestrations and branches is durable. The risk of target instability is higher with renal versus mesenteric arteries, and greater thoraco extent is associated with increased target artery instability. The group here led an analysis looking at sex-related outcomes and showed that women experienced higher rates of technical failure, non-home discharge, postoperative sac expansion, and device design efforts are needed to improve outcome parity. Next study was 893 patients led by the UNC group looking at octogenarians, showing that fenestrated branched EVAR was effective with nearly identical early outcomes in octogenarians, and that midterm freedom from branch instability and secondary intervention were also similar between groups. My group had the opportunity to lead this analysis looking at fenestrated branch for failed EVAR. We showed that fenestrated branched EVAR was safe and effective in patients with prior failed EVAR with nearly identical outcomes compared. Differences in procedural metrics do indicate a higher level of technical challenge when performing fenestrated for failed EVAR. And fenestrated branched EVAR at high volume centers is a viable option for the treatment of EVAR failure that actually far surpasses results with historical reports of open conversion. The group here again did analysis now with 1681 patients looking at secondary interventions. Dr. Zettervall presented this at the SVS VAM meeting, showing that secondary interventions are common, with the majority being minor, low magnitude, and percutaneous, and that a significant level of reintervention does not negatively impact survival, and that a reasonable rate of reintervention may actually be a marker for good care, meaning you're following these patients closely. The UAB group, led by Adam Beck, looked at this group of 1681 again, looking at spinal cord injury, identified risk predictors for spinal cord injury, and showed that poor survival was associated with patients who developed permanent paraplegia. The UAB group did another analysis looking at aneurysm extent-based mortality and actually compared our experience in this PSID studies to the VQI more national experience, and clearly showed that patients repaired in PSID studies had better perioperative and 1-year survival compared to the patients treated in a real-world registry, regardless of the extent when stratified. And the reason for these differences could be related to device differences, durability issues, differences in patient comorbidity profiles, volume-related outcomes, and IDE team infrastructure. And then the most recent study was 1681 patients looking at upper extremity versus transfemoral access for these cases, showed that transfemoral access has a lower rate of perioperative cerebrovascular events compared to upper extremity access, that overall cerebrovascular events for upper extremity access was acceptable to justify use in these repairs, and that transfemoral access should really be preferentially used in most patients, particularly those that have favorable anatomy for it as we get more comfortable with steerable sheaths. So the last database freeze for the consortium data was 1681 patients. As I showed you, we're now up to around 2,500, but you can see really the whole range with lots of 644 extent 1 to 3 thoracos. And I think what we're particularly proud of is this 30-day mortality. So if you look in the 1681 data set, the mortality is 3% for 30-day. And looking into the database last week, if you look at the 2,543 patients, it's hovered right there at 3.1%. And again, I want to go back to this slide I already showed you to put that in context. This is open thoracal repair at the highest volume, most outstanding centers, potentially, I think it's fair to say, in the world. So we're really proud of this 3.1%, and hopefully we can keep it there. So what do I believe the deliverables are from the United States Aortic Research Consortium? It's the largest data set of fenestrated branched EVAR in the world. It's a core group of investigators committed to improving patient care and pushing the envelope on endovascular therapies from the aortic valve to the common femoral artery. Not only are we working on understanding the data from ARC, but we're also having now every other month, we have a case conference. Actually, Matt's leading it this coming Monday, where we go through a complicated case and try to learn from each other. And that's a reminder, Matt, that you're leading it next Monday. It's high quality adjudicated data that's harmonized across sites. It's an engine for the exchange of ideas and promotion of these technologies, ideally within the US and across the globe. We've now created the infrastructure and a more agile regulatory pathway for testing emerging technologies to obtain preliminary data. It's generalizable data that's a departure from just single center reports. We've been able to standardize some best practice and build consensus around a suite of products and techniques. This is just an example, a paper I didn't show you, but this is a white paper we wrote where we basically just assembled all of our practices around managing lumbar drains, and really were able to come up with a shared sort of what we believe is best practice. We also have the infrastructure to conduct randomized trials. So something I'm really excited about is last week at UMass, we randomized the first 2 patients in this trial, looking at therapeutic lumbar drains versus prophylactic lumbar drains. And for having the infrastructure in place through ARC, it's a much, much cheaper way to run a randomized controlled trial since we already have it. So ultimately, hopefully, it's more patients getting better care by more providers using fenestrated branched EVAR devices. And again, we talk about inflection points. I think this is really an important inflection point in my career, where hopefully we're now going up the green line. I think one thing that's important to understand with these repairs is that they are radiation intense. And if you look across the types of procedures that are done using X-ray, actually complex endovascular thoracoabdominal repair is the most radiation intense. And that's what really led me to look for ways in which we could think about mitigating radiation. And, you know, if you look out in the public press, there's concerns about the radiation that patients get. But I think much more important for this type of repair is actually the providers that are standing next to the X-ray emitter for an entire case. And we've started to see lots of publications about healthcare teams that are having effects from radiation. And I think we all know of people and have thought about people that may have actually had really sort of significant life-changing events based on the radiation exposure. So I had the opportunity to collaborate with Philips on a new technology. This is called fiber optic real shape. This enables real-time 3D visualization of the full shape of devices inside the body without the need for radiation. So basically what this allows us to do is put fiber optic cables along a wire or a catheter. And, you know, how did I become involved in this? Basically by writing a paper about our radiation doses and how high they were, and the fact that on the first Monday of the month, I get called by our radiation safety officer every month to tell me that I'm above the limit. Don't share that with mom. Basically, I was able to collaborate and come up with this technology. We're the first in the United States to use it, where we have a workstation, an engine that's about the footprint of a Bovie stand, and then this docking adapter that lets us use this radiation-free technology. So I'll just show you what this looks like. Hopefully this video will play. But you can see here, we're in the room. This is our hybrid room. We're setting up our system where we're plugging in the devices. I'm sorry, it's so jumpy. And we're basically plugging in these catheters and wires that have fiber optic cables in them. Let me see if I pause it, if that will play a little normally. Here we're registering it. So we take one flat plate X-ray in order to tell the system where the wire and catheter is. And then here, I apologize that the video is so jumpy, but basically we've put a yellow wire into a target artery, and then we follow that out with a catheter. We're using no X-ray right now. We're not pressing the pedal. We're just watching this simulation of where the wire and catheter are in three-dimensional space in order to cannulate each target artery. Again, I'm not sure why the video is jumping so much, but We do it one at a time. We do it in a much more fluid way than this is showing. And then we leave a wire behind in each target artery. And able to get sort of our standard completion studies afterwards that does use radiation. And then ultimately, ideally get a 1-month scan that looks normal. Sorry that this laptop doesn't seem to be able to handle the video. So that's kind of an interesting opportunity where we got to be involved in this technology really early. Now it's being used at 3 sites in Europe and 4 sites in the US. And I think it has the potential to really change the way we think about endovascular repair. Kind of another inflection point was thinking about sort of how do we use data in a different way in order to better take care of these patients. That led to a collaboration with a company called Illuminate that's based out of California. And what this technology allows us to do is put it within the firewall of our system and go through our electronic medical records and look for any patients that have aneurysms. So you can see here, basically radiology reports and clinical notes get fed into this engine. It uses natural language recognition in order to identify any patient that has an aneurysm, whether they're followed or not. So patients we've lost to follow-up, patients that come in the ER and get a study for something else and are found incidentally. It then gets tuned based on our notes, which we've gone through that process. It gets validated, and then it can start putting individual patient records into buckets based on aneurysm size. And then we use this Acknowledge platform to basically follow these patients, reach out to them. This is what it looks like on the back end. Basically, it's looking through every clinical note and report and imaging study to see keywords about aortic aneurysms. It then scores it. So like this patient at the top left has a 95% likelihood of having an aneurysm. And you can set your threshold for sensitivity. And this is just a report that I pulled on August 28th. So the system so far has gone through 7.5 million imaging studies. It's identified 7,300 patients that have aneurysms. There are 2,150 that my nurse navigator is still reviewing. There are 4,039 that have already been reviewed, and there are 1,191 that are sort of in the process of being reviewed. And then if you look at this bottom row, this is just a sense of over the last 18 months, what the yield has been. So it's about 71 finalized imaging studies, 24 imaging studies that patients are coming in the next couple of weeks, 104 new patient clinic visits, and then 8 aneurysm surgeries. This is the average contribution margin calculated by one of my partners, Fran Aiello. And then looking at the line item billing, it's contributed about $500,000 to our bottom line. So I think it's been interesting to see that. So in conclusion, I think the path from here to there is really easy to see when you look back, but it's completely obscure when you look forward. Follow your passion. Everything else takes care of itself. I really believe that. As I kind of indicated, bringing enthusiasm and passion to the table can actually take you a long way. I think the important part is just getting to the table, just being a part of it. And then evolving advanced endovascular technologies are not iterative. They're transformative, and it's a privilege to really be a part of this new technology and this transformation. I put this slide up in almost every talk I give, and I'll put it up for you guys as well. I believe that during my career, all aortic pathology from the aortic valve to the femoral artery will be treated with stent grafts. I also think that during my career, endovascular aortic repair will be performed without the need for radiation. I think that there are going to be medical students that like come up to talk to Dr. Starnes and say like, so explain that to me one more time. Like you'd stand there for 3 hours right next to this energy emitting X-ray machine. And that's how you did the repairs, because it's kind of insane that that's the way we do it. And you know, this idea of aortic valve to femoral artery, we're actually getting pretty close. So this is a patient that we did an arch repair, then we extended it with a 4-branch repair. We've still got some problems to solve, but I think we are getting closer. And in many ways, I think it's amazing that you can do these types of repairs and then end up, you know, with just Band-Aids. This is a patient that we just did a arch repair on using actually unilateral femoral access, and then the other side was just for a transvenous pacer in the femoral vein. But I would say while the Band-Aids are pretty, and that's nice, what's really amazing is seeing patients that look like this. So I put this one up just because this is 7 days out from an endovascular type 2 thoraco repair. And I would argue that there is not a patient in the history of aneurysm repair that looked like that at 7 days after an open type 2 thoraco, period. Walking into clinic of his own strength from his home, doing this well 7 days out. And I could show you pictures of his aorta, but I think what's more important is just seeing what he looks like. And this is 7 days out, but we've now got a lot of patients that are 7 years out. And it's been fun to see patients actually exit from our IDE study. This is Earl Baumgardner. It's actually someone that's worked with Shireen as well with some of the connective tissue disorder work that she does. And he's really been a great partner for our program and has been involved really in spreading the message. So I want to close just with one final case, because I think this in some ways really represents the front edge of the technology of where we are. So this is a 75-year-old man. He was referred for degeneration of a known aortic dissection. 6 months prior to seeing us, he had had a type A dissection with an open repair, and then subsequently had a left common carotid to subclavian artery and TEVAR. But there was a dissection around the arch, so not surprisingly, it didn't seal. So he was found to have a persistent type 1A endoleak. And what was concerning is that just in 6 months, it had gone from 4 centimeters to 7 centimeters. So this is what his CT scan looked like. It goes kind of fast, but there's a type 1 endoleak and now a 7 centimeter arch aneurysm. So what was a little bit complicated about this case is that he had a bovine origin, so a common origin for the innominate and the carotid, but it was about 22 millimeters in diameter. So we were able to come up with a plan where we worked with the engineers to fashion a graft that would fit his anatomy and allow us to put both branches through that common origin, that bovine arch. So we do some back and forth with the engineers. We come up with a plan like this. This is what this case looks like in the OR. So here we got bilateral percutaneous groin access. We did a right carotid cut down, and we did left high brachial access. We then use some of these new innovative imaging technologies. You can see there we have a 3D mask that we just rotated to fit the angiogram, so we know exactly where everything is without having to fluoro, just using this 3D roadmap. Here you can see we're advancing the device and getting it in proper position. We're looking at all those marks to line them up with the wires that are coming down from the head vessels. We then open up the device. We do this with rapid pacing, which really stops the heart, so there's not motion. And you can see here we're unsheathing the device. We then first position our innominate bridging stent. So this is now coming down from that carotid cut down. We deploy that by unsheathing it. So you'll see that stent graft expand as we pull back the sheath around it. Now with that deployed, we take a picture just to make sure we have a good seal there. We do, so we move on now to the left carotid. We deploy the carotid bridging stent. That's a balloon expandable one. Then we take another picture, make sure there's a seal there, and then get a completion image where you can see now the aneurysm's completely excluded, and we've bridged the ascending surgical graft to the previously placed TEVAR. And this patient had an uncomplicated postoperative course. He was actually discharged on post-op day 1. We treat these patients with Plavix, and you can see here his CT scan. Now the aneurysm is completely excluded. The branches are patent. And I think you can also appreciate that the geometry going through this common origin, since it was 22 millimeters, accommodates both branches just fine. And again, I think it's important, we look at these pictures, but it's also really neat to see what this patient looks like. So this was a couple of weeks ago in clinic. Again, 5 days out from an endovascular redo aortic arch repair. Again, at home, able to ambulate on his own. Really exciting. So I think it's fair to say that we've really come a long way. I think on a personal note, I feel extremely fortunate to be able to be a part of these developing technologies. And I think it's not really necessary to look too far into the future. We see enough already to be certain that it will be magnificent. So hopefully, those are some of the dots that give you a sense of kind of how I've connected them to be a part of being on a team that can create a program like this and really be able to sort of push these technologies further. And hopefully that was interesting for you. I do want to close with one last slide, and I'll have you sort of come into my office a little bit. So like many people, I've got a lot of knickknacks in my office, a lot of memories from visits, but I want to point out one special thing. So this is a letter, and I'll read it to you in a sec, but to give you some context, I wrote a paper in 2011. It was pretty controversial at the time, and I got a lot of criticism. In fact, a lot of criticism from kind of leaders in the field around this paper. So much so that actually several wrote to circulation where the paper was published, asking for it to be pulled. One of actually Dr. Sweet's mentors, who knew a lot about this topic, was really concerned about the quality of the data. But what I would say, and this is for the young people in the room, don't take yourself too seriously. This is a letter to the editors written by my niece, who was in 5th grade at the time. And she says, "Dear editors, please leave my Uncle Andy alone. He may not know a lot about arteries and veins, and his research may be terrible, but he is a great uncle. My Uncle Andy takes me camping, he buys me ice cream, he's a great soccer player, and he's even sat through my 4-hour dance recital 2 years in a row. Now say you're sorry." So at some point, you know what? You just kind of do your best work. So thank you all very much for the opportunity to present our experience, and really an honor to be here. Thank you.
Andy, that was really wonderful. That was wonderful. Questions for Dr. Schanzer? I have a question. I know that there are some questions on the screen probably, but you're a director of the Heart and Vascular Institute, and cardiac surgeons are also very much involved in performing open aortic arch reconstructions and that sort of thing. So how does your team incorporate the cardiac surgery service? Do you have somebody who's intimately involved with that? We have Chris Burke, who's interested in this, and Dr. Daru. So how do you do that?
Yeah, so I'm glad you asked that. So I think actually not having a good partnership with cardiac surgery is one of the common fail points for programs like this to evolve. So we have 4 cardiac surgeons in our group, and then there's one of them that I partner really closely with. So his name's Rick Bello, really talented surgeon, really also interested and supportive of these evolving technologies. We have a clinic together on Mondays, so we actually are co-localized in the same clinic. So in real time, I'll see a patient, and then I'll pull him in, and we'll talk about the patient, and then we'll talk to them about, the most common collaboration for us is kind of around the elephant trunk type of thing and sort of figuring out ways to create landing zones. But there are plenty of patients that I get referred for endovascular that then I say, you know what, let's talk about it. And we decide that he's better treated with an open repair. So I think that's a key part of it. And the way we've done it is by co-localizing our complex aortic clinic to have it at the same time. So we look at those cases together in real time. So I talk to them every Monday.
Yeah, that's great. It's very similar relationship here through the aortic conference. Other questions? Dr. Zetterball.
That was an incredible talk.
Oh, thanks.
As we're seeing this evolving technology that totally is transformative, particularly in force and such, it's also expensive. How have you approached getting, buy-in from hospital leaders to make these?
Yeah, so I think that's a big issue because the technologies are expensive. We've been able to sort of champion the support moving forward in a few ways. One is what I tell our administration is this program is not going to make a lot of money, but it's going to break even. And we've been able to keep it at slightly profitable as opposed to a loss, because I think it's hard to sustain a loss year in and year out. And we've been able to negotiate with the manufacturer to give us a really good rate on these devices. And again, that's part of this sort of partnership with industry. The other piece, and I track this and I have slides about this, is we look at a few things. So one, the number of imaging studies that get done for these patients that normally are attributed to radiology, they actually come on my P&L. So their CTs and their ultrasounds actually come on our profit and loss statement because those are pure profit. And I think it's important that that gets counted. And then the other piece is what we sort of call this halo effect. So the complex aortic program, we've been fortunate in that we get programs, patients from all over the country for that. And often once they come to us for their complex aortic repair, not only do they come back for reinterventions as necessary, but they get a heart cath with us, or they come back to get, you know, a cancer resection down the road at UMass because it's now become their hospital. So one thing that one of my partners, who I think you know, Fran Aiello, has set up is we actually follow these patients prospectively and we capture an accounting of all of these sort of future visits. And that's been really important for me to be able to show our administration. Yes, we run kind of at a break-even point, but if you start counting sort of these other patients that are new to our system that wouldn't have been here if not for their complex aortic program, it brings in extra revenue. So that's how we've done it. But I think it's really important. You have to do that in order to show them. And I don't know how much pressure you guys get around that, but we've felt it's really important to keep an accounting of that. And I'm lucky because I've got this guy, Fran Aiello, who's just like a savant for this type of stuff. So it's really fortunate.
That's great. Other questions? Dr. Shelby?
Really fantastic. I love the little dots along the way. So kind of corollary to Sarah's question, you know, in terms of funding the research aspect of things, again, that's sort of thankless work. Usually hospital administration doesn't want to pay for that.
Yeah, so that is hard, and it's a constant process. I can tell you the way we started the program is I applied for a UMass, not UMass Hospital, but a University of Massachusetts project development grant, and that gave me an initial $300,000 to kind of have staff to do it. Because right now I have a full FTE research coordinator, 2 research assistants, and 1 nurse practitioner, and 1 administrative assistant, just for the Center for Complex Aortic Disease. And now we've been able to get those FTEs transitioned to be supported by the hospital because of the program.
Dr. Zhang?
That was a great talk. Question is like both branch TMR and vascular TMR can be used to treat the program, and also which technique, which one?
Yeah, I think we're still trying to figure out exactly the right spot for each. Speaking about it really simplistically, fenestrations, you have to be a little more precise, but when they line up just right, and there's not a bridging distance between the graft and the target artery, I believe that's the best strategy. A branch, what's nice is it gives you a lot more technical freedom because it's easier to target a target artery if the branch is offset. So if I'm really concerned about a cannulation and the directionality of the vessel, typically if it's downgoing, then I'll use a branch. The one area that I feel pretty strongly about is when I did the first sort of arch repairs as we started our experience, and this is true kind of to the international experience, we started using fenestrations. And I don't know if you guys have used fenestrations in the arch, but it's a really bad idea because you just lose all manipulative ability to rotate it to the right spot. So that's one area where I feel pretty strongly that you really need to use branches because you need to be able to allow for a little bit of offset and not have to try to manipulate a graft in the arch because as we talked about yesterday, stroke is really the Achilles heel there. And I think as you start bringing grafts up and down and trying to rotate them. So the way we do arch grafts now is we just bring it up and we leave it there and deploy it, and then we work on the branches.
Dr. Singh?
Andy, wonderful talk as always. One of the things you mentioned was, we talked about it briefly yesterday, was some of the illuminate the sort of artificial intelligence that goes through records. You know, how, you look through 7 million, you get all of it, boil it down to 8 operations. And how do you justify that to your institution that this is something you need to think about?
Right.
You showed the platform.
Yeah. Yeah, so I would say 3 ways. So the first is from a population health perspective. So if you look at even a site like this, where you take great care of patients, your loss to follow-up will be a lot higher than you think. And I was struck by that when I applied for my IDE because the FDA asked me to show our follow-up for EVAR. And I said, like, sure, I'll show it. It's around 90%. And it was 42%. We just lose a lot of patients. So one is kind of, the population health aspect of it. The other is using it as a research tool. And we were able to show our administration that it would be valuable to be the first academic center in the United States to use this. And we've already presented our experience at our national meeting in Europe and now coming up at the NASVS. And then the third, you have to have a business plan and a business case. And even with just those 8 surgeries, which I agree to me seems like a pretty low yield for all the work, $500,000 of contribution margin, actually over 18 months, is pretty good. If you look at sort of our total contribution margin on the hospital side, it's around 12 to $14 million, depending on the year. So if you look at $500,000, that's a pretty good bump to that. So we were able to get the hospital to actually pay for the nurse navigator that does it based on this business plan.
I guess you can partner, right, with other divisions, right, certain things, that they're looking at.
Yeah.
Nodules.
Yep. Yeah. And like, for example, the nurse navigator we use is our division quality officer. So she does other quality improvement projects as well.
Other questions? Well, I want to acknowledge someone on the Zoom call. This is Tom Pham at Harborview. Hi, Andy. We were co-chairs or
Yeah.
co-chiefs at UC Davis in 2005. I just want to congratulate you on your great work and career, Tom.
Thank you.
The other thing I wanted to point out is to acknowledge one person in this room. I'll take you back to the year 2004. I was driving home from Madigan after a long day at work, and I was listening to NPR, and they announced that the first FDA-approved thoracic stent graft in the United States had been deployed at the University of Washington.
Mhm.
And who was it that did that? Mark Meissner, sitting in the back of the room. So Mark, congratulations on that accomplishment. I know you're very humble and you're sitting in the back of the room, but that was the first graft in the US.
Yeah, that's
FDA
really neat.
approved. So Andy, thank you for a wonderful
Yeah,
talk.
thanks
and a
for the
wonderful
opportunity
few
to
days,
visit.
but,
Yeah.
Let's give him a round of applause.